So very good morning, one and all. So we are coming to the 5th edition of the online anesthesia postgraduate teaching program on the Zoom platform sponsored by Aquila and hosted by AO Logistic. Today we have 3 topics to discuss. The first topic is the physiology of one-lung ventilation by Dr. Sivaprasath, followed by the rare topic, that is anesthetic implication of mediastinal mass by Rakesh Garg. He is a known author of the textbook of anesthesia for Onco surgery. He is a well-known speaker from AIIMS, Delhi, and that will be followed by a video presentation of segmental epidural, a practical approach by none other than Jennyl Maclean. He is a famous ultrasound guided trainer in all India level. So with that introduction, I request Guru Sidhya to introduce the first speaker, Dr. Sivaprasath.
Good morning all. Welcome you all to the Thoracic Anesthesia Part 2 session. It is my pleasure to welcome Dr. Sivaprasath sir, who has been my assistant professor as well. He has completed as MD from 2004 to 2007 and is an assistant professor of anesthesiology in Madurai Medical College from 2008. Over to you, Sivaprasath sir.
Good morning, everybody. I hope you would have all enjoyed the Thoracic Anesthesia Part 1 series. Today, we are going to have a talk on one-lung ventilation, its physiology, anesthetic implications, and management of hypoxia. To start with, I would like to quote that a deep understanding of physiology will make this science into an art. So we'll move on to look at for a case scenario. A 55-year-old female patient is scheduled for right upper lobectomy. So in the last class, you would have had a deep insight into how to assess a patient who is posted for a lobectomy or a pneumonectomy. And you assess this patient, prepare this patient, bring her onto the table, and you insert a 37 left-sided DLT and confirm the correct position by FOB. One lung ventilation and lung isolation are confirmed by auscultation. So this part also we have covered in the last week sessions. And after 10 minutes of one lung ventilation, the SpO2 starts to gradually fall to 88%. So now few questions should arise in your mind. If only one lung is ventilated, the saturation should have been 50%, right? Why is it only 88% now? And what are the causes of such desaturation? And how to prevent such episodes of desaturation and how to improve the oxidation in the intraoperative period? For this, we have to understand some core concepts. We will go on with 5 core concepts today. So we'll understand what are the regional differences in ventilation in our lung, what are the regional differences in perfusion of our lung, the ventilation and perfusion changes when a person changes from upright to the lateral decubitus position, and ventilation strategies that should be employed during one lung ventilation, and if there is a hypoxia, how to manage it. So these 5 topics we'll discuss in detail. To begin with, we'll go in for the regional differences in ventilation. In this session, we are going to talk about transpulmonary pressures and trans-airway pressures, time constants and indeterminants, regional differences in ventilation due to gravity, and regional compliance curve. So there are pressure gradients that cause ventilation. What are they? You all know that the lung is an elastic structure. It always tries to collapse itself. The rigid chest wall cavity prevents this collapse, and as a result of this, a negative pleural pressure is formed. So this negative pleural pressure will keep the alveoli partly open and filled. This forms the FRC, and the pressure involved in it is called the transpulmonary pressure, which is the difference between the alveolar pressure and the pleural pressure. During inspiration, as this chest moves away, the negative pleural pressure increases and reduces the alveolar pressure. So you can see in this graph, from -5 centimeter, the intrapleural pressure has become more negative to -8, and it is converted itself to a reduction in the alveolar pressure from 0 to -1. This difference between the mouth, the upper airway pressure, and the alveolar pressure will cause the air to flow inwards. And I also would like to stress on the point that this reduction in alveolar pressure or the changes in alveolar pressure are uniform throughout the lung. So with this alveolar pressure, the air starts to flow into the lung and starts filling the alveoli. There are a variety of alveoli filling at different times. So normally, the time taken for an alveolus to fill to 63% of its capacity is called one time constant. The time constant is a product of the resistance into compliance. Here, we have to consider many types of alveoli. This is the normal alveoli, which will fill in 0.5 seconds. That is 5 time constants. The alveoli will fill 100% with normal compliance and normal resistance. We consider here one alveoli which has high resistance. See, the normal resistance is from 0.7 to 1. So here in this alveolus, the resistance has become 1.4. So this alveolus will take a longer time constant and fill with less of air. And there is another alveolus which has decreased compliance. This also fills less, but it has a very short filling time. Look at the time constant. It is only 0.28 seconds. So different alveoli fill with different time constants, and based on what resistance and compliance is there in that alveolus. Many factors influence the compliance of this alveoli. One of the major factor which is very physiological is the gravity. So if you hold a plastic bag filled with water, you know that the lower part will become sagging and it become bulged. This is because of the gravity of that water forcing on the lower part of the plastic bag, which pushes it outwards. Similarly, lung is also a viscoelastic bag and it sags at the bottom. See, the lung contains elastic tissue and fluid components. So its own weight pushes it down. The hilum does not support the lung. So it is only the lung that supports itself. So the chest, as I already told you, the chest wall is a rigid cage, and it does, and because of this rigid structure, the pleural pressure, which we saw already, it was minus 5 centimeter water in the resting phase. But because of this sagging, what happens is in the upper part of the alveoli, the pleural pressure becomes more negative, that is minus 6.5 centimeter water. And in the basal region, it is almost positive, it's plus 1 centimeters of water. I remember the intraalveolar pressure is constant throughout the lung. It is a transpulmonary pressure that keeps the apical alveoli and ducts more open and larger even at the end exhalation. That means in the upper part of the lung, the alveoli remain open, and because of the weight and the pleural pressure, the lower part of the lung, which contains these alveoli, are compressed a bit. And these compressed basal alveoli remain more compliant. The upper alveoli are already filled up and it is tensed. It cannot move further. The lower basal alveoli are collapsed and they have more chances of expanding. So look at this. Now the chest wall is expanding. What happens is the negative pleural pressure becomes more. It becomes more negative from 6.5 has become minus 10, and the lower part it's become minus 4. What happens is the chest starts and the lung starts to expand. See, you can see that the basal areas expand more and the alveoli are filling better in the lower areas. So if we can correlate with the regional compliance curve, see there are few alveoli here, the lower zone, the middle zone, the upper zone. Whichever alveoli fill the best for a given pressure, this alveoli will be depicted at the steep part of the compliance curve. See, for a given change in pressure, they are filled with more volume of air. And these alveoli which are less compliant, or that is that they do not fill well with the give same change in pressure, they will be depicted in the flat part of the compliance curve. This you have to remember, because with this diagram, we will be taking the further sessions on lateral ligament disposition. So you have to remember that if an alveoli is highly compliant, it's filling with a lot of air for a given change in pressure, that alveoli will be depicted at the steep part of the compliance curve, and those alveoli which are less compliant will be depicted in the flat portion, either in the top or in the bottom, it will be depicted in the flat portion of the regional compliance curve. Now moving on to regional differences in perfusion. The regional differences in perfusion have two factors. One is the passive factor, that is a gravity, and active factor, that is a hypoxic pulmonary vasoconstriction. We all know that the perfusion is dependent on SVR, the lung volume, so many factors. The first factor which we are going to discuss is the lung tissue. We know that the right lung contains more lung tissue. That is why the cardiac output is distributed 55% to the right lung and 45% to the left lung. Depending on gravity, we see the heart is at the vertical center of lungs. So this is the vertical center, and the total vertical length of lungs is 30 centimeters. So from this midline, we have 15 centimeter up and 15 centimeter downwards, and this creates a pressure gradient. So for this 30 centimeter, from top to bottom, if you measure the vascular pressure, there will be a difference of 22 millimeters of mercury. If it is a systemic circulation with the 120, 80 BP or a mean of 90, nothing is going to happen. But for a pulmonary pressure, where the mean pulmonary pressure is 15 millimeters of mercury, this becomes very significant. What I mean is, if it is at the center, the pressure is 15 millimeter mercury, the topmost part of the lung will have 11 millimeter mercury difference. That is, the perfusion will be only with 4 millimeter of mercury, and the lowest part of lung will be 15 plus 11, that is 26 millimeters of mercury. So that is a huge gradient from the top to bottom of the lung with respect to the pulmonary pressures. So the lung tissue which distributes the blood and the gravity that distributes the blood regionally, these two form the passive factors. And coming to west lung zones, depending on this passive factor, gravity, in 1962, Permut defined two zones of lung, the upper zone and lower zone with respect to the pulmonary. He found that the upper zone has less pulmonary pressure, the lower zone has higher pulmonary pressure. It was in 1964, West divided the lung into three zones, the zone 1, zone 2, zone 3, depending on the alveolar pressure, the alveolar volume, and the pulmonary and the pulmonary venous pressures. And in 1968, Hughes, he discovered that there is one zone 4 that exists, and that affects the lung ventilation clinically. So this is one diagram. All the postgraduates should practice very well going before the exam. If you draw this one diagram and this question is asked, and looking at this diagram itself, the examiner will know that you have understood the subject well and will give you full marks. So let me dissect this diagram by each pixel and describe you. Going on to the zone 1. Zone 1 is called the region of collapse, which means the vascular pressures are lower than the alveolar pressures. Whenever I ask what is zone 1, the students used to tell me, sir, the alveolar pressures are very high. Actually, the alveolar pressures are almost uniform throughout the lung. It is that the pulmonary vascular pressure is lower than the alveolar pressure. So in this zone, see, you can see that the intra-alveolar vessels are compressed by the existing alveolar pressure itself. The extra-alveolar pressures are not, vessels are normal. The intra-alveolar vessels are compressed. So because of this, there is a ventilated and an unperfused area, and the VUQ ratio reaches 3, and it gives a huge alveolar dead space. You might be wondering why this creation is like this. Such a wasted ventilation in the zone. Normally, this zone is very small, and it has got some uses also. This region forms a ready-to-be recruited vascular area. So that is, if you all know that the cardiac output is 5 liters. Sometimes when you exercise, the cardiac output can even rise up to 30 liters. During the times of physiological stress and high cardiac output states, these zone 1 lungs will open up and allow more blood to be flown through the lung. If this is not there, your pulmonary pressures will rise very heavily. So this is one physiological state. Let me discuss the pathological states little later. I'll just mark a red star here, and I'll just discuss it little later. So there's very less amount of West zone 1 in a normal healthy lung. There are two caveats. Look at this. If you give positive pressure, that is, if you increase the alveolar pressure with high tidal volume or a high PEEP, then the zone 1 is bound to increase. Or if there is a hypovolemia like blood loss, improper fluid administration, the lower pulmonary pressure will create an increased zone 1. We all know that the zone 1 is not good. So if you're going to increase the alveolar pressure or you're going to decrease the pulmonary pressure, the zone 1 is going to increase in the lung. We move on to zone 2. Zone 2 is called the waterfall alveolar area. Here, see the description. Pulmonary pressure regularly exceeds the alveolar pressure. So when does it exceed? Whenever there's a systole. So the capillary flow here will depend on the arterial to alveolar pressure difference. Whenever the arterial pressure rises just above the alveolar pressure, there's a flow. Whenever the alveolar pressure is higher than the arterial pressure, the flow is stopped. So in this diagram, you can see that the pulmonary is a little bit opened up. There is one region of small constriction and the pulmonary venous flow is also occurring. So this area was called the waterfall zone, the sluice zone, or the Weir's analogy zone. This is because you can see this picture here. This is the dam. So this is the dam wall. So whenever the waterfall in the upstream rises above the dam wall, there will be water flow. Whenever the dam reservoir has less water, there won't be any flow. In a similar way, cyclically, there is blood flow through the alveoli in this zone 2 region. In the lower portion of zone 2 and the upper part of zone 3 has the best PQ ratio area. So these are the areas which are actively participating in good oxygenation. Coming to zone 3, this is called the zone of distension. Here, the blood flow becomes continuous. Remember, in zone 2, it was cyclical. Here, the blood flow becomes continuous because both the pulmonary vascular pressures, the pulmonary artery pressure and the venous pressure exceed the alveolar pressure. So there is no external resistance here. See, the alveolar pressure is not giving any resistance. The flow is continuous. And this is the ideal place to wedge a PA catheter tip. See, I have placed a catheter tip here. Once the balloon is not inflated, it is going to measure the proximal PA pressure. And when I'm going to inflate the balloon, it is going to measure the distal, that is the pulmonary venous or the left atrial pressure. So zone 3, you always wedge the pulmonary catheter tip to measure the pulmonary pressures. And coming on to the hugest zone 4, or the place where interstitial pressure exceeds the pulmonary venous and alveolar pressure. Here, the blood flow will be dependent on the difference between pulmonary pressure and the interstitial pressure. So does this exist normally? No, it is not normal to exist. If you look at the physiology books, only zone 1, 2, 3 will be there. Zone 4 will exist only in anesthesia books. So it occurs whenever the lung is at very low volume. Example, an atelectasis, or there's a pulmonary edema which occurs in the interstitium. In these times, the interstitial pressure will rise. It will compress the extra-alveolar blood vessels. See, in this diagram, you can see that the extra-alveolar vessel is very small. Some amount of flow is occurring in the intra-alveolar vessels. So clinically, what happens is, when you have a one lung ventilation going on, you overload this patient, or you don't apply proper PEEP, there is something which develops called a down lung syndrome, and which has unilateral pulmonary edema in the dependent lung. So this should not occur. That is why the importance of zone 4. And pathology, remember we had a small red star when we were discussing in the zone 1. Here, if you have some pathological conditions like mitral stenosis or left ventricular pressure, which is going to increase the pulmonary venous pressure, the blood flow will become very, very poor in this zone 4 area, or in the zone 3 area also. So it is at this time, the blood flow will go through the zone 1 and get oxygenated and come to the systemic circulation. So that is the importance of zone 1. If there is high interstitial pressure in zone 4 and zone 3, the pulmonary blood can flow through the zone 1. We already saw that the capillary flow is by the arterio-interstitial gradient. So if you look at this diagram which we had in the earlier phase, you can see that in zone 1, this is the blood flow and this is the pressures. Here there was no flow at all. In zone 2, there was some flow. In zone 3, there is a maximal flow. And when the zone 4 started occurring, the blood flow started to decrease here. You can see that it's a decrease here. And in addition to all the VQ mismatches, because of this interstitial pressure, the oxygen in the alveoli won't be able to reach the pulmonary capillaries very well. So the shunt fraction will increase if you are going to produce a zone 4 in this lung. So this is the passive factor which we have discussed. Now we are going to talk about the active factor which is going to produce regional distribution perfusion. That is the hypoxic pulmonary vasoconstriction. The general rule in our body is that whenever there is hypoxia, there is vasodilation. The only exception here is the HPV. HPV is the reflex vasoconstriction of pulmonary artery smooth muscle in response to hypoxia. So it was first observed in 1852 by Buechner. So it was very long back. In 1852 itself, he found that whenever there is hypoxia, the pulmonary pressure is going to rise. But it was in 1922, Haldane proposed the physiological role of HPV. It was in 1946, Van Euler and Liljestrand, they produced a seminal paper on this HPV. So what does this paper say? It describes that hypoxia is a more potent pulmonary smooth muscle constrictor than hypercarbia, and it even occurs in denervated heart. Even if you have a transplanted lung, this HPV will be active in that, and endothelium is not necessary for this HPV to occur in lungs. So this was the landmark work of Van Euler and Liljestrand, and this phenomenon is named as Liljestrand phenomenon after him. So what are the physiological stimuli for HPV? So the main stimuli are the partial pressures of oxygen in the alveoli and to some extent in the pulmonary venous blood. So the pulmonary alveolar oxygen partial pressure is a more potent stimulus here, as you can see through this formula. So the range at which the PaO2 range in which the HPV is very active is 40 to 100 millimeters of mercury. Once the alveolar oxygen tensions go below 100, the HPV mechanisms will in the pulmonary vasculature will become very strong. And where does this occur? It occurs in small vessels, pulmonary capillaries, which are 50 to 200 micrometer in diameter. And it is very active when the 30 to 70% lung becomes hypoxic. The most important factor is, see, whenever you have a hypoxic alveoli, how much of HPV blood flow reduction will occur because of HPV? It is only 40 to 50%. So suppose 100 ml of blood is flowing through a lung tissue, which is totally cut off, the ventilation is cut off in that lung, only 50 ml will reduce. Rest 50 ml will still pass through that lung tissue, which is hypoxic. You have to remember this throughout this presentation. I'll be talking about this HPV, which can reduce a shunt by 50%. We'll keep on telling about this, you'll have to remember this. So how does this mechanism occur? The sensor for this mechanism lies in the electron transport chain. See, suppose you have enough substrate, the energy substrate and oxygen, the ETC chain will go unobstructed and a lot of intermediate metabolites will be formed. That is the NAD, FAD, the reactive oxygen species, the hydrogen peroxide, all this will keep the pulmonary capillaries in a vasoconstricted state. Once there is a lack of oxygen, all these intermediate substrates in the electron transport chain will reduce. The NAD will go down, the FAD will go down. The reactive oxygen species that is generated by the electron transport chain, they also will go down. So that is sensed by the potassium channels which close, and they open the calcium channel, that is the Rho mediated calcium channels open, and a lot of calcium enters into the pulmonary artery smooth muscle. Because of this, the pulmonary artery smooth muscles contract and they produce HPV. So what is the role of endothelium? Endothelium acts as a modulator for this reflex. Even this reflex can occur without endothelium, but if endothelium is there, some amount of modulation occur. The negative modulators being prostacyclin nitric oxide, if these two are not there, the HPV will not occur well. And if there is thromboxane and endothelium, this HPV reflex is augmented. What is the physiological role of HPV in our body? It's mainly the fetal pulmonary arteries. You know that all the blood that reaches into the right ventricle does not go through the lung in the fetus. In turn, it goes to the truncus and the foramen ovale. So the unventilated lung produces a intense vasoconstriction in the pulmonary arteries, and this is the main physiological role of HPV in the fetus. In adults, it produces uniform matching of ventilation perfusion in a healthy lung. In a diseased lung, the role of HPV is that if you have an asthma or COPD, the 100% oxygenation worsens hypoxia is because of this. And ALI, ARDS, high altitude pulmonary demand, development of pulmonary hypertension, all dependent on the HPV reflex. So what are the characteristics of HPV response? You can see here there is a biphasic onset. Once the hypoxia sets in, the HPV response will start in a few minutes, and in 15 minutes it will plateau. This is called the first response. And within 15 to 20 minutes, the second response will start and will plateau in 2 to 4 hours. And in this diagram, you can see that there's an offset also. You restore the euoxia, the hypoxic pulmonary response also should go down, but that does not occur. It takes some time to for the HPV itself to offset, and that is the reason for hypoxia after receiving a 2-lung ventilation. See, suppose you have a lung case and you're taking it down in 1-lung ventilation, and the surgery is over and you start ventilating both the lungs, there will still be some amount of desaturation. That is because the HPV response offsets little late, and it has a preconditioning effect also. Suppose you produce some amount of hypoxia in the ventilated lung before the surgery, in the intraoperative period when you produce a lung isolation, HPV response will be very intense. That is called the preconditioning effect. So there's an exhaustive list of factors that alter HPV. We'll see some. In patient factors, you have patients who have COPD, sepsis, pregnancy, female sex, and cirrhosis, who have less amount of HPV, and people who have systemic hypertension, they have very good HPV response. Metabolic acidosis and respiratory acidosis and hyperthermia can really produce a lot of good HPV response in a patient, whereas alkalosis and hypothermia will inhibit this response. And perioperative factors, lateral decubitus position and surgical retraction can augment the HPV response, whereas Trendelenburg position and hemodilution will inhibit this response. Coming to anesthetic factors, it is commonly thought that all volatile anesthetics inhibit HPV. It is only true with regard to halothane and nitrous oxide. For desflurane and sevoflurane, it is actually not really proved. And the ketamine, opiates, propofol, dexmedetomidine are all safe. Epidural anesthesia and inhaled nitrous oxide actually do not produce any change. A small mention about propofol, dexmedetomidine, they have found that it can actually augment HPV and produce a good response. So if you have a desaturation during an 1-lung ventilation, probably instituting propofol anesthesia can improve HPV and increase the oxygenation. Coming to vasoactive agents, all sildenafil, nitroglycerin, sodium nitroprusside, all these drugs produce vasodilation and they attenuate the HPV response, which is not good for us. Something more interesting is noradrenaline also inhibits this HPV response. By contrast, phenylephrine is the only vasoactive drug that produces good HPV response. And in the recent finding, it was found that patients who had iron infusion, they had very poor HPV response. So what they did was, they tried chelating the iron with desferrioxamine, and they found that these patients have got very good HPV response in the intraoperative period when they face hypoxia. The other drugs are almetrin, was previously used to augment HPV, especially in patients who had ARDS, but now it is not used because the benefit ratio is very small. And indomethacin and aspirin also can augment HPV. So coming to the third section, we are going to discuss about lateral decubitus position. And in this, there will be 5 positions which we will discuss. And in the end, we'll also talk about one position, that is a spontaneous chest open position. We already saw that in the upright position, the alveoli in the apex are already distended and they don't get ventilation much. So the lower basal alveoli, they for a given amount of alveolar pressure, they expand very well and they remain in the steep part of the regional compliance curve. So the same thing happens when the patient lies down. What happens is dependent alveoli go into the steep portion of the regional compliance curve, and there is a 10% increase in ventilation to that dependent side. And also the diaphragm contracts better on the dependent side, and on the whole, the dependent lung receives better ventilation when a person assumes lateral decubitus position. He is awake with his chest closed. So you have to remember that whenever a person lies down, this lower lung will get better ventilation. So what happens to the perfusion? Once a person assumes a decubitus position, immediately the cardiac output will go better to the dependent lung. There's a 10% increase. So 50-50 if it was happening, once a person lies down, his dependent lung will start to receive 60%, and the non-dependent upper portion of the lung will receive 40% of the blood. So if right lung was up, remember we had a regional difference with respect to the lung tissue. So normally the right lung will be receiving 55% of blood. Once a person lies down on his left side with the right lung up, the 55% will come down to 45%. If his left lung goes up, the 45% will come down to 35%. To conclude, we can see that the dependent lung receives more perfusion. So the ventilation and perfusion are perfectly matched in an awake closed chest state. So once you anesthetize, what happens is the perfusion is same. The perfusion is better on the dependent lung. But what happens to the ventilation? The mediastinum and abdominal contents will start resting on the dependent lung. They will give more pressure. So the compliance goes down. So because of this, and the diaphragm which loses its shape and contraction, the ventilation decreases in the dependent lung and starts to go to the non-dependent lung. So this is called a climb down effect in the compliance curve. You can see that in an awake lateral decubitus position, the dependent lung was on the steep portion of the regional compliance curve. Now what has happened is the non-dependent lung has come to the steep portion. So the ventilation is better on the non-dependent lung and the perfusion is better in the dependent lung, creating a VQ mismatch. So once you open the chest, something drastic happens, which is very bad. So in the non-dependent lung, the ventilation starts to become more and more. So because the restriction in the chest wall is lost and ventilation is by positive pressure, the VQ mismatch aggravates, and more so if the patient is paralyzed. So to summarize these three things, from upright, if you go to the lateral decubitus position, the dependent lung receives better ventilation and better perfusion, hence VQ mismatch is preserved. But the same person, once anesthetized, the non-dependent lung receives better ventilation and dependent lung will be better perfused, giving rise to VQ mismatch. And once the chest is open, the ventilation is much more into the non-dependent lung and the perfusion still remains in the dependent lung, giving rise to a huge VQ mismatch. What happens when you do a one lung ventilation? So once you deflate the non-dependent lung with help of say a bronchial blocker or occluding the DLT, so the lung is deflated. So what happens is, now we have seen that 40% blood was flowing in the non-dependent lung and 60% was there in the dependent lung. So this 40% blood is going to flow through the non-dependent lung still, because we only stopped the ventilation, perfusion is still there. So then the HPV has also not come into effect. So blood flows through the deflated lung and shunt fraction increases. How much? The QS by QT is 40% here. Without HPV, so much of blood, deoxygenated blood is going to join the oxygenated blood and the oxygenation drastically decreases. That is what happens when you initiate one lung ventilation. There will be a drastic fall in the PaO2. Sometimes we may not notice it until the surgeon starts to do his work. But what happens is, if you suppose ventilating with 100% oxygen, the PaO2 starts going down. As soon as the one lung ventilation is initiated, carbon dioxide excretion remains normal. That is what you have to know. So once the HPV starts to occur, I have already told you that HPV is 50% efficient. So blood flow to the non-dependent lung reduces because of passive factors, that is gravity, surgical interference, and deflation. Now HPV starts occurring. Now it is already 3 to 4 minutes have started once the OLV is instituted, and actively the deflated lung, those pulmonary arteries are starting to contract. So the blood is going to come down to the dependent lung. How much? So the 40% fractional blood flow, 50% reduction, it has come down to 22.5%. Still, some amount of blood is flowing through the non-ventilated, non-dependent lung. So you have to remember that there is still a shunt fraction there, even if there is a good amount of HPV that occurs after lung deflation. So what are the ventilation strategies when you institute OLV? So this is similar to ARDS. You will have to institute lung protective ventilation with an open lung concept. We are going to discuss about tidal volume, respiratory rate, FaO2, the mode of ventilation, airway pressures, and how to recruit. So once you start OLV, you have to see to that you have to give lung protective ventilation, that is 5 to 6 ml per kg and not 10 ml per kg. What happens? You see, there is a tendency to hyperventilate and give more tidal volume when you do hand ventilation. That should not happen here, because anything more than 8 ml per kg is associated with acute lung injury and pulmonary edema. I already told you, pulmonary edema zone 4 will increase. And in the postoperative period, ALA will set in. Increased pulmonary vascular resistance in the ventilated lung will push the blood into the non-ventilated lung, and auto-PEEP can occur. So you have to always have tendency to ventilate only with 5 to 6 ml per kg. Respiratory rate anywhere between 12 to 14 is fine with an IE ratio of 1:2. If the patient has COPD, reduce the respiratory rate so that the IE ratio becomes 1:4. Adjust the minute ventilation so that you have a PaCO2 of 40 to 70 millimeter mercury. 70 is fine. Even if it is 50 to 60, it is fine. You have to use the lowest FaO2 to achieve a PaO2 of 90 millimeter mercury. Brief periods of 100% oxygen will not cause atelectasis if there is PEEP added into the ventilation strategy. And you have to be highly cautious about lung injury when you are giving 100% oxygen to patients who are already on bleomycin. Which mode of ventilation is the best? As you can see here, we have a flow time graph for VCV and PCV. Volume control ventilation delivers tidal volume in a square wave pattern. That is, it will generate a positive pressure in the airway, sustain it for some time, and once the flow and the volume has occurred, it will terminate it. But when you look at PCV, it is a decelerating pattern. At the early part of inspiration itself, it will deliver more gas into the alveoli and slowly it will come down. So this is more physiology. That is what happens in a natural ventilation. Once you start your inspiration, a lot of gas will flow into your lungs and slowly it will come down. So this is more physiological, and during the later part of the ventilation, uniform distribution of tidal volume can occur. This will improve the oxygenation, and this also will result in lower peak and plateau pressures because gas distributes evenly into the whole lung, and there is lesser incidence of lung injury. With all modes compared, PCV is the best mode you can use in one lung ventilation. And how will you set PEEP? For setting the PEEP, you will have to look into the ventilator graphics. So titrate the PEEP using a PV loop in the ventilator. So this is a PV loop. You can see there are this is the inspiratory limb and the expiratory limb. Inspiratory limb has a lower inflection point at which the lung starts opening up, and an upper inflection point where the alveoli start to become distended. So you'll have to note this lower inflection point and slowly start increasing the PEEP so that the LAP, that is lower inflection point, starts to disappear. See, I'm increasing the PEEP from 1, 2, 3, 4, 5. Bingo. Here you have a PV loop which has no lower inflection point. This is the place where alveoli start to remain open. And you have to observe for auto PEEP. Don't adjust anything. Keep observing for a few breaths. Suppose the PV loop starts going more and more above the 5 centimeter water, it means that auto PEEP is setting in. At this point, you will have to reduce the PEEP level or increase the exhalation time. It is especially very important in patients who have obstructive type of lung diseases. And almost a maximum effect will be achieved when you set PEEP at 10 centimeter water, above which this PEEP will increase the shunt fraction. And that is that it will divert the blood from the dependent lung into the non-dependent lung. So to be very careful not to set high PEEP levels. So why are recruited maneuvers important? The lung protection ventilation by low tidal volume, 100% oxygen administration, and compression of the dependent lung by mediastinum, diaphragm, and the retractors all predisposed to atelectasis of the dependent lung. So you will have to institute some recruited maneuver. So any recruitment maneuver at least need 40 centimeters of airway pressure to keep that lung open. To achieve that, you can use a opening pressure in the PCV mode at 20 centimeter water, and you can gradually titrate. Do not give 20 centimeter airway opening pressure with a PEEP of 20 together 40. It will immediately produce pulmonary edema. So slowly, again acute lung injury. So slowly increase PEEP from 10, 5 breaths, 15 PEEP, 5 breaths, and 25 breaths, and then go to your normal mode of ventilation with an IE ratio of 1:1. So whenever you are giving a recruitment maneuver, be very cautious. Don't hand ventilate. You might actually end up in lung damage. And use lower FiO2, because high FiO2s during a recruitment maneuver will produce a lot of oxygen toxic radicals and look for re-expansion pulmonary edema. So what will you do if this you're ventilating very nicely, you're very scientifically setting these ventilatory parameters and ventilating? What happens if you come across some hypoxia? So in this session, we'll see what are the predictors of hypoxia during one lung ventilation. First one is, if you have a preferential perfusion to the operative lungs. The operative lung is the non-dependent lung. If you, in your preoperative VQ scan, or if there's a right side that's lung surgery where the lung tissue is more, or if there's a previous contralateral lung surgery like lung reduction surgery in the dependent lung, these situations you have to be very careful when you see such patients. It means that in the intraoperative period, you will experience more amount of hypoxia. And in the pre-op ABG, if you see a wider A minus A CO2 gradient, it means that this space will be there. If you see that, this patients also will have more hypoxic episodes when instituting OLB. And one thing, see, if you have a normal FE even during pre-op PFT, sometimes it will also produce more hypoxia. Why this controversial thing? It means that if you don't have obstructive disease, auto PEEP won't occur. If there is no auto PEEP, sometimes you may land up with de-recruitment when you use 100% oxygen. That is why if you have a normal FE even in the pre-op, you might land up with hypoxia in the OLV. And if you have desaturation even with 2-lung ventilation, it definitely in 1-lung ventilation, you will land up with hypoxia. And surgery in supine position, because these VQ mismatch is very severe in supine position. So there also you will have more hypoxia. So what should you do when there is a desaturation in OLV? The first thing you will do is increase FiO2 to 1. Then you will have to go for a quick checklist. So in this checklist, you will see whether there is any DLT malposition or kinking, any secretions that are obstructing. If there is a pneumothorax, because you are using high pressures in the different lung, there might be a pneumothorax or a bronchospasm, or you might have a low cardiac output and low blood pressure, or any problem in the machine and giving a low FiO2 or hypoventilation. So after giving FiO2 of 1, you have to go for a checklist of all the mechanical factors that can produce a hypoxia. If all this is not there in spite of FiO2 1, it means that this hypoxia is due to shunt. If it is due to shunt, the next thing what you will do is, there are two things which you can do. One is you can reduce the shunt, or you can oxygenate the shunt. See, the shunt means the blood that is flowing through the upper lung, is operated lung or the non-dependent lung. So there is blood flowing through that, and even with 100% oxygenation, you are not of the lung which is down, you will always have hypoxia. So the best method is to reduce that shunt or oxygenate the shunt. So to reduce the shunt, you'll stop if there's an NTG going on for high blood pressure, stop that NTG. If there is an inhalation, it's a little bit controversy. If you have an inhalation agent, you can stop it and go in for propofol anesthesia, which is better. And you can apply CPAP to the non-dependent lung. So that will actually compress on the pulmonary arteries in the non-dependent lung and push the blood down. So in a way, it can reduce the shunt. Or if nothing works, you can ask the surgeon to quickly ligate the pulmonary artery, which is going to reduce the blood flow through a non-ventilated lung. So how will you oxygenate the shunt? You can apply the same CPAP to the non-dependent lung. So that will also help in oxygenation, or intermittent 2-lung ventilation. Though it can interfere the surgical field if there is no other go, you can go for 2-lung ventilation. But if you can selectively ventilate the non-dependent lung, that is much more good. You can actually pass in fibrotic bronchoscope, and you can slightly ventilate the lobes which are not operated upon. And if nothing works, the only thing which will help is ECMO or a CPB when you have to continue the surgery. We'll discuss some about how to use CPAP in the non-dependent lung. So this is the situation we are having. The upper lung, which is having a surgery, is non-ventilated. You have isolated this lung, and the dependent lung is getting full ventilation. But some amount of blood is flowing through the non-dependent lung also, which produces a shunt. Now, what you're going to do is, you're normally in your ventilation strategy, you're adding PEEP to the dependent lung. This PEEP is going to compress the alveolar vessels and we're going to push the blood into the non-ventilated lung and increase the shunt. This should never be done. Increasing high levels of PEEP on the dependent lung is always deleterious. So what you will do is, you will add CPAP to the non-dependent lung. This is going to push the blood from the non-ventilated lung into the ventilated lung and it improves oxygenation. So the take-home thing is, if you want to give high amount of PEEP in the dependent lung, it is going to be disastrous. You always have to do with some amount of CPAP to the non-dependent lung. So a summary of hypoxia management: ensure maximal two-lung ventilation. Till the time you can do a one-lung ventilation, go on with a two-lung ventilation. And if there's a hypoxia that occurs, go in for an FiO2 of 1. If there, and with once you institute FiO2 of 1, go in for the mechanical factors. Check the position of DLT and check for the cardiac output. See, there's one thing: if you if the low cardiac output, there is going to be hypoxia. If there's high cardiac output also, you will increase the shunt fraction and produce lesser PO2. So there should be an optimal cardiac output. Decrease the volatile anesthetic vasculitis and use propofol instead. You can use differential CPAP and PEEP, which I have already told you, or partial ventilation of the operative lung, oxygen suppletion into the non-operative segments, or high frequency ventilation into the non-dependent lung, or a selective lobar collapse with the help of a bronchial blocker. All this can slightly reinflate the operative site and it can improve the oxygenation in the patient. Or sometimes you will have to go on for a pulmonary occlusion earliest by the surgeon. And this intermittent reinflation, deflation is really disturbing the field. You should always do it only when it's needed. And if nothing was, you have to go for a ECMO or a CPB. In conclusion, we'll just 2 more slides. What is hold? So I already told you about open chest and spontaneous ventilation. In the olden days, when they were not having facilities to control the ventilation with the neuromuscular blockers, they were using spontaneous ventilation. So when they did thoracic surgery with spontaneous ventilation, patients and surgeon, both anesthetists also, all had respiratory distress and then they lost the patient. It was because of 2 factors. The first is called the paradoxical respiration. The second is called the mediastinal shift. In paradoxical respiration, what happens is, when the chest is open and the patient takes an inspiration, you can see in the first diagram, the air moves from the atmosphere into the dependent lung and also from the non-dependent lung. So from there, air enters into the dependent lung. So during an inspiration, if you see the operative field, the lung will collapse. During exhalation, what will happen is, from the lower part of the lung, that's the dependent lung, the air will move out into the atmosphere as well as into the operative lung. So during exhalation, the lung will bulge out. So this constant movement of lung inflation, deflation during exhalation and inhalation is called the pendulum phenomenon. So this is very disturbing. And what happens is, when you take an inspiration, the air which is already in the lung, in the upper part of lung, will come back into the dependent lung. So this will produce hypoxia and a lot of respiratory distress. And in a similar way, whenever there is an inspiration, the lower part of lung will have an intact pleural cavity that will pull the mediastinum down. And during exhalation, the mediastinum will come up. So the total mediastinum will be moving. The lung also will be moving. This was in the days of spontaneous ventilation. These 2 phenomena are called mediastinal shift, paradoxical respiration, which gives to pendulum. After the advent of controlled ventilation by paralysis, this has gone down. Now we are in an era of VATS. So in the era of VATS, something new has produced interest, that is called the NIVATS. NIVATS means non-intubated video-assisted thoracoscopic surgery. So in NIVATS, what they do is, they combine regional anesthesia like intercostal block, paravertebral block, or a serratus anterior block. So one regional anesthesia with spontaneous GS given. So what is the advantage is that the spontaneous ventilation will improve the VQ ratio and produce better oxygenation. This is the new concept in one lung ventilation. So I'll give you 8 take-home messages, two in bunch together. The first two are, until you anesthetize in a lateral decubitus position, VQ are best in the lower zone. Once you anesthetize, you paralyze and you open the chest, the VQ mismatch is such that the ventilation is in the non-dependent lung and the perfusion is in the dependent lung. And always HPV is only 50% effective in diverting blood away from the non-ventilated lung. You should remember this. So the rest 50 you should take care of. And proper fluid therapy and cardiac output management are preemptive and preventing hypoxia in the intraoperative period. So many times we always look at the managing the ventilatory strategy. If you miss the preoperative fluid therapy, perioperative fluid therapy, or the cardiac output management, still you are in a position to land up in hypoxia. And it is always better to use anesthesia ventilator with graph and scalar rather than hand ventilation to have a scientific management of one lung ventilation. So whenever you have a hypoxia, you should always check for mechanical factors before branding it as hypoxia due to shunt. So if there is a mechanical factor, however oxygen you are going to give, 100% oxygen you are going to give, you are not going to improve. And 100% oxygen is an immediate solution, but it is not the only solution for hypoxia. But now you would have understood that you can oxygenate the shunt, you can reduce the shunt with many other factors. So 100% oxygen is not the only solution to hypoxia. CPAP to the oxygen with oxygen to the non-dependent lung reduces as well as oxygenate the shunt, and high PEEP alone to the dependent lung can aggravate hypoxia. With these few words, I thank the online anesthesia team for giving me this opportunity to take this class. See here, when you do a OLV in the most scientific way, you can have a lot of happiness below your cap, and you can see the happiness behind the mask of your surgeon, see how happy the surgeon is. So after this, OLV should be an easy job for you. Thanks a lot. Thank you very much.
Thank you, Sivaprasath, for a wonderful lecture. Guru Sandhya?
Yes, sir.
There are 2 questions in the chat box.
Yes, sir. Seen, sir. Sir, how to identify down lung syndrome or unilateral pulmonary edema in the intraoperative period apart from desaturation, sir?
Identify. One second.
There's the chat box.
Sivaprasath, sir?
I'm not able to unmute myself, sir.
Shilpa? Shilpa, please make Sivaprasath a co-host.
Okay, sir. Is this audible, sir?
Yes, audible. You please go on.
I'll answer from my mobile, sir. Identifying pulmonary edema is actually a little bit difficult. You won't know why the desaturation is occurring. Probably even if you have, after increasing oxygen levels, still you have desaturation and your filling pressures, that is the CVP or your PA pressure is very high. That might be due to pulmonary edema. Until a frank pulmonary edema froths out of the tube, you won't know it is the pulmonary edema that is occurring. So you have to be really careful about the proper fluid therapy and the cardiac output.
So next question.
So the next question is, sir, any change in perfusion and ventilation lateral decubitus position with slight head up position, sir?
There won't be any change. It's still the lower lung is down. The same VQ mismatches will be occurring, and even with slight head up, nothing will, no change will occur.
Okay, sir. Parthasarthi sir has asked, we accept a saturation up to 90%. Is it okay? Sir? Shiva, sir?
As long as your PaO2 in ABG is 90, it is fine. If you go on to the steep part of the ODC curve, then if it is saturation 90%, if there is some amount of small secretion or any small tube kink, then you will start to have a rapid downfall of saturation. So maintaining PaO2 at 90 millimeter or above is more important than the SpO2.
Okay, sir. So Selvakumar sir has asked, if desaturation occurs during one lung ventilation, what is the first step you do?
Always the first step is 100% oxygen.
Okay, sir.
So the common next question they ask in the exam is how to give CPAP to the non-dependent lung and PEEP to the dependent lung. So this is a common question they will ask the exam.
Just a second. The CPAP is always given through a CPAP valve, sir. 5 liters of oxygen should be set in with a rebreathing bag and a CPAP valve should be attached. And only with that we have to give CPAP in the non-dependent lung.
So you are going to use 2 machines or a single anesthesia machine?
If that is not possible, you can. Sorry, I'm really sorry.
Yes.
If that is not possible, you can attach a pediatric circuit with a pop-off valve open and set 5 liters and see to that the pediatric bag does not distend. The pediatric bag is only half-liter bag. So approximately 5 centimeter to 10 centimeter water pressure will be achieved with this flow rate in a pediatric circuit.
Yes, sir. So this is the answer you have to say in the exam. And there is one more answer is given is, suppose one anesthesia machine is available, you can partially upload the non-dependent lung port and use a single anesthesia machine. That is also it is given, but it is how much pressure it will be built up in the CPAP is not known. So thank you, sir.
So it is always better to use the CPAP valve and give it, sir.
Yes, CPAP valve, that is the ideal method. You have to give, use a CPAP valve and with a separate circuit you have to give. Thank you. Any other questions? So thank you. We will move on to the next session. For the next session, thank you, Professor. For next session, I invite Dr. Rakesh Garg. I am very happy to introduce my friend Rakesh Garg. He is an additional professor from the Department of Onco-Anaesthesiology and Palliative Medicine, All India Institute of Medical Sciences, New Delhi. And he has many number of publications in his credit. He has published more than 260 publications in the international, national journals, and he authored 25 chapters in books. It is a great achievement. So he is an editor-in-chief of Journal of Onco-Anaesthesiology and Perioperative Medicine, and associate editors of Journal of Anesthesiology and Clinical Pharmacology and Journal of Medical Case Reports. And he has conducted many workshops on the ACLS, BLS, BCLS, CCLS, and his area of interest is onco-anesthesia. He has written a textbook on the anesthesia for oncosurgery. And he received many awards and achievements. He received IAC President Award in 2021, 2017, 2015, and IAC Privacy Award in 2019. And he has got the Academic Excellence Award in 2018, IAC Bhopal Award, and many more achievements in his credit. With that few introduction, I would like to invite Dr. Rakesh to deliver the rare topic. The topic is less discussed in many of the CMEs. So it's a less discussed topic. So I request Dr. Rakesh to deliver this lecture. Welcome, sir.
Thank you so much, sir. Thank you for the kind invite to be among the dear friends and seniors for an interesting topic, which is very core to me, and we are doing it very routinely. Quite challenging, but yes, interesting. And if we just understand the basic concepts, I think it's not tough to manage these patients. So once again, thanks to Dr. Edward Johnson and all his team for such a good initiative to interact with postgraduate students so that we learn from each other, and also whatever experience we have, we can share with them. Thank you so much. I bring greetings from my institute. I work at All India Institute of Medical Sciences. So when we talk about the mediastinal masses, we have a lot of mediastinal masses that needs to be operated upon in the thoracic cavity, but almost 3% of tumors will be the mediastinal masses among all the tumors in the chest. And the age variability is very much. It can be seen in pediatric age group. So though the type of masses, the lesions, benign or malignant, would be different with regards to age, but they can involve all age groups, even pediatrics, young adults, elderly populations, and older populations. And hence, the assessment and evaluation would primarily also be based on the demography of these patients. These masses could be primary or secondary, but the basic issue is when these masses exist in this narrow space, which is a restricted space, a lot of symptomatology happens because there are various cardiovascular and hence the manifestation of the symptomatology is important. And also during the surgical management, since they are operating near the lesions, so there again would be issues wherein they can have such type of perturbances in the perioperative period, which needs to be taken care of. Now, this will be a commoner case since many of here postgraduate students. Just let's take an simple case here: a 42-year-old male who presented with progressive shortness of breath, dry cough, weight loss, chest pressures since 1 month. The shortness of breath was worse by lying supine, and it is better in the lateral position. So I think, as previous speaker was also talking, this will be a commoner manifestation of any of the mediastinal lesions. So when you are doing a pre-anesthetic checkup for these patients, do look for those symptomatology. If they are present, yes, this means there is a mediastinal mass, and that needs further assessment and evaluation. This is just not for the patients who are coming for the surgical procedure, but at times there could be other masses which have extension into the mediastinum. And hence, when you are evaluating these patients, be careful to look for these symptoms so that you can pick them early and manage the patients accordingly. Usually the hemodynamics may be a little variable in these patients, may change with position. There may be edema in the upper head and neck area, and there may not be any findings in the chest cavity usually because the mediastinum is a closed space, so they may not affect the respiratory symptoms from the auscultation point of view. But if you see the effort tolerance with regards to the when we say about the assessment of these patients, there would definitely be concerns about the respiratory assessment because the mediastinal mass will definitely be compromising the respiratory aspect as well as the cardiovascular aspect, which can affect the respiratory system again. So you should be very, very clear that on auscultation, you can see, you can listen bilateral equal air entry, but still these patients can have a lot of issues that needs to be taken care of while you're managing these patients. Now, let's understand what this mediastinum is. Now, this is a structure which is between the pleural cavities that contains the heart, cardiovascular organs, and other thoracic viscera, including the cardiovascular system, the lymph nodes, and other aspects, except the lungs. If you see the boundaries of this structure, that mediastinal structure, the anteriorly it is by sternum, posteriorly it is bounded by vertebra and paravertebral spaces. The superior aspect is usually labeled as thoracic inlet, inferior it is by diaphragm, and laterally it would be a parietal, the reflection of the pleura, which is labeled as parietal pleura, which is the mediastinal side of the parietal pleura. And if you see the various structures that are available in the mediastinum, usually if you divide this mediastinum, it could be the anterior mediastinum versus posterior mediastinum. Also, the anterior mediastinum do have composition which can be further classified as anterior, middle, and superior mediastinum. If you see the structures among these and see the anatomical structures available, majority of time, the patients who are coming for surgical procedures or various pathology are usually restricted to the anterior mediastinum, and they are little of more concern to us. The structures which are in the posterior mediastinum, specifically the esophagus, patient can come for esophageal surgery, but their concerns are a little different. So probably I may not be covering that part today because esophageal surgeries are altogether a different type of surgical procedure. So we'll discuss it sometime. But anterior mediastinum are very peculiar for its finding, for its surgical approach, for perioperative care, and then it becomes very, very important. When we talk of the middle mediastinal structure, it's usually the cardiovascular surgeries. So they have, again, a specific set of symptoms which are usually managed by a cardiac anesthesiologist into a different setup. So when you say a non-cardiac anesthesiologist, the challenging group of pathology would be primarily restricted to the anterior mediastinum, or maybe they may be extending into the superior mediastinum, like, for example, when we talk of the thymus glands. And these whole structures, what they will affect on the management plan is we have to look for at what type of lesions they are. There could be an extrathoracic lesion, that can cause flattening of the inspiratory limb of airway collapses during negative pressures, especially affecting the respiratory system. There could be intrathoracic mass, or there could be fixed lesions. So these are more of a terminology with regards to when we try to divide these mediastinal masses based on the respiratory manifestations. I'll come a little later once again when I'll be discussing about these respiratory components of it. Now, these patients become these pathology. Usually, majority of patients that we are operating surgical procedure will be the thyroid lesions, and more common will be thymomas, which are in anterior mediastinum. And they can also sometimes be into the superior mediastinum. The thyroid gland sometimes can extend retrosternally, and it extends into the superior mediastinal structures. So the manifestation and the management plan, or the perioperative probably both these structures of anterior mediastinum and superior similar. Hence, the management needs to be patient have approach being. For the mediastinum, it is more of a cardiovascular surgery. It could be even the bronchogenic cyst also. The lymphomas are usually not posted for surgical procedure, except the biopsy procedure. Sometimes these patients may be posted for mediastinoscopy and biopsies. Otherwise, they are usually managed with the medical management. For posterior mediastinum, usually the esophageal masses or the hiatal hernia is the common surgeries. The spine tumors are usually approached most of the time from the posterior aspect, but yes, some of the time, especially when the fixation is being done, they may also be approached from the anterior side, especially when you talk about the kyphoscoliosis and all those. There could be an anterior approach also, but they have different, usually managed by neuroanesthesiologists, they have different concerns. So today, majority of things I will be restricting my talk towards the peculiar concerns of the management of various pathologies into the anterior and superior mediastinum. These are the 4 tumors that you are usually managing it: thymoma, teratomas, thyroid lesions, and terrible lymphoma. Sometimes when you need a biopsy for them and they're obstructing lesions, you need some stenting and henceforth. As an anesthesiologist, why do you be needed for these patients? Either for a diagnostic procedure, or it will be for definitive or therapeutic procedures. Diagnostic procedures, these patients usually we get a biopsy done, CT-guided biopsy, because since they have near vascular structure, the chance of bleeding or respiratory compromise can happen. That's why usually these are under monitored anesthesia care, and you may be called for these type of procedures. Anterior mediastinoscopy, they may be done under local anesthesia usually, but sometimes ES is required, and hence require the anesthesiologist. The other commonest procedure that we are doing nowadays, and that is replacing the CT-guided biopsies or mediastinoscopy. And I think any one of you who are working in bigger centers, this is one of the upcoming procedure, and majority of place it is replacing the CT-guided procedure. This is called endobronchial ultrasound-guided transbronchial needle biopsies or aspiration. So this requires a special concerns, and hence we need to understand. For therapeutic procedures, usually these require sternotomy or tracheotomy for the excision of biopsies, and this can now be done with video-assisted and more commonly, more recently by robotic-assisted thoracoscopic surgeries. Now, coming back to the same patient which I mentioned earlier. So if we talk about the same patient, 42-year-old male, when these patients are sent to you by the surgical colleagues, how will you evaluate these patients? What are the concerns that needs to be looked for? So when we're talking about these patients, we need to look for various concerns, and those can be picked up on a thorough history and physical examination, including certain focus investigations, and then probably based on history examination investigations, you may require to rehabilitate. So since anesthesiologists are a part of various rehabilitation program, so you should also be a part of optimizing these patients through various rehabilitative procedures so that these patients are taken care of. Now, this is the summary what these patients can have when you are assessing these patients. There could be factors which are related to patient-related factors. There could be anesthesia-related factors, or there could be surgery-related factors. So you have to see all those factors when you're managing or assessing these patients or evaluating these patients into a pre-anesthetic checkup. When I talk of patient-related effect, there are 2 things. One thing is the generalized effect of the tumor. For example, say thymoma. Thymoma may have issues with regards to the the muscular involvement, the effect on the muscular activities. There could be general effects like dysphagia. These masses can be pressing backwards, and that can lead to dysphagia with poor nutrition. There could be chances of infection, infective pathologies. Because of the nutritional issue, they can be anemia. So, but more concerned structures that needs to be looked for and assessed appropriately, and hence requires proper planning for perioperative management. For the cardiovascular structures, this can cause arrhythmias, filling defects. If they're pressing over the cardiac structures, they can have filling defects on the heart itself, and hence they can have a lot of cardiovascular compromise. There could be vascular compression like superior vena cava syndrome or right ventricular outflow tract obstruction can be happening because of these masses which are compressing directly over these structures. There also could be a pulmonary vessel compressions which can lead to various cardiorespiratory compromise, and hence needs to be looked for. With regards to the respiratory components, they can compress upon the main tracheal portion, the main airways, including trachea, or maybe the bronchus also. And hence, there are more chances of these patients suffering from recurrent infections of the respiratory system. At times, because of the reactive reaction, they can have pre-refusion, and hence they can be a good amount of respiratory compromise, leading to decreased amount of respiratory reserves, which our previous speaker was also discussing at how the atelectasis and issues can be chipped in because of these issues. And these patients have poor respiratory reserves, and they can lead to more amount of hypoxemic episodes during the surgical procedure. Now, when we try to evaluate these patients, since these patients are picked up incidentally majority of time and they are looking for some minor symptoms, they are usually asymptomatic, or they may have minimal to moderate symptoms like chronic cough, which is ruled out, and then they are found that a mass is irritating the bronchus or the recurrent laryngeal, which leads to cough. They can be having some amount of dyspnea on exertion, chest pain, fatigue, or vocal cord paralysis. But the main issue is if they are present late and they are minor subset of population, but they can have compressive symptoms, and this could be because of trachea or main bronchi or large vessels or on the cardiovascular structures, or because of the systemic effect like myasthenia gravis and thyroid disease, and that can lead to the manifestation of severe symptoms. Usually these are a very small set of populations, but yes, it needs to be looked for. More likely, the anterior mediastinal masses causes a lot of cardiorespiratory problems, and hence we should be focusing the evaluation part, the assessment part, and then planning accordingly to take care of this. Let's see this CT picture. So as an anesthesiologist, we should also be a little well versed how to assess these patients from the imaging point of view. Clinical presentation, we already discussing, and then subsequently you should also be clear about the assessment of these patients using various imaging modalities, and you should be discussing with your radiologist. The point why I'm emphasizing here is majority of time when you see a CT picture and you see a CT reporting or an MI reporting, they may not be much commenting upon the airway structures as such. They will be just saying that they are compressing the airways. But how much is the lumen of the trachea? How much is the lumen of bronchi? Because you'll be requiring a one lung ventilation, and hence it becomes essential for us to understand, to assess these things on the imaging also, or we can discuss with our radiologist colleague and then try to find out these findings. Now, with regards to the tracheobronchial compression, when you are assessing clinically these patients, look for the signs of severe dyspnea, stridor, chest pain. These patients can have tachypnea, they can have bronchi or decreased breath sets, especially when they are having either the obstruction or because of the infections. And these are usually exacerbated in supine position, depending upon the size of the mass. The severity may not correlate with the degree of compressions because depending upon the age, sometimes the structure are well fixed, they are well supported. But in elderly population, the support system, the fibrocartilaginous or fibrous bands, they are not so strong, and hence the symptomatology may be manifested much severe in elderly population. Also in children, these can have symptoms earlier than adults because they have a smaller airway diameter, and they have, because of the less cartilaginous support these structures, they can have decrease in the tracheal diameter. That can lead to increased airway resistance, and hence manifestation of airway symptoms are much higher. In case they compress upon the vascular structures, and most common vascular structure is SVC compression, and that can lead to the decreased drainage of the SVC drainage area. And it can be because of various malignant. Majority of time it is malignant. Majority of time it is various mediastinal structures, and especially the apical portion of the lungs also. But they can be sometimes the other non-malignant region, almost in 15% of cases. And usually these patients will, majority of time, will manifest dyspnea. They can have facial swelling, and you can see a lot of venous dilatation. And if they are not managed immediately, they can have CNS symptoms primarily because of the venous congestion of the head and neck area. And this can be exacerbated in supine or leaning forward position and coughing, because that will increase more of a venous congestion. And hence the symptoms assessment needs to be done for these patients. Now, in case if they are pressing on the right heart, that is right ventricular outflow obstruction can happen, or pulmonary vasculature, these patients can have dyspnea, syncope, they can have arrhythmias, they can have cardiac murmurs. And hence, when you are assessing these patients, try to look for these features also. Now, just to summarize, coming back to the same patient, what features I have just mentioned, that these patients, when they come to you, the main aim for assessment or evaluation is to identify these patients for high risk for cardiorespiratory complications, cardiovascular and respiratory complications. Hence, based on this, you should look for the various symptomatology. And you should also look for the severity of symptoms that I just have discussed with you, whether we are talking of the respiratory systems or the cardiovascular system or the cardio or the CNS system. So try to look for the symptoms and the severity, and accordingly you need to grade them as mild, moderate, or severe. And depending upon this, you can just not only prognosticate, try to rehabilitate and plan your anesthetic management accordingly. Now, same patient, when we see the clinically, this appears to be a mediastinal mass. But as I just mentioned, that we need to look for the other investigations, to look for the other manifestations. The first usual screening imaging will be the chest X-ray. We need to look for both the views of X-ray, the PE and the lateral views. And you can see usually a mass-like structure. You can see the structure here, which is on the anterior mediastinal mass. And you can also see there will be a broadening of the mediastinum here, mediastinum silhouette will be widened here, and hence it will give you a clue that the location and probably the impact of various structures that is happening in these patients. You can also see whether there is some amount of tracheal deviation. If you see this X-ray, you can easily see this mass is sitting here, and this is impinging on the trachea, and the trachea is being shifted towards the other side. And hence, this type of findings should give you a clear-cut conclusion that yes, probably depending upon the size of lesion, you need to look for other modalities, and the CT scan remains one of the important modalities that you should also look for when you are assessing these patients. This is one of the most appropriate modalities because it can give you an accurate size, the extent, the location, the relation to the other structures in the mediastinum, and the level and extent of the airway compressions, especially with regards to the tracheal diameter, tracheal cross-sectional area at the point of compression. And also we monitor some, or we measure some other parameters like mediastinal thoracic ratio and mediastinal mass ratio. So these are the measurements wherein you measure the mass versus thoracic ratio, or you measure the mass versus the mediastinal diameter. And based on this, it has been well established that those patients who are having a tracheal diameter because of the compression mass of this mediastinum less than 30%, they have respiratory systems. If they have more than 50% of compression, they will have more issues, specifically leading to complete obstruction of the airway. Mediastinal thoracic ratio more than 50% at a high risk, and mediastinal mass ratio less than 30% indicates small mass, 30 to 40% medium mass, and more than 40% large mass. And large mass has a high propensity for various cardiorespiratory diseases, and hence it becomes essential that when you look through imaging, these type of parameters are usually not reported on the reporting format of the CT scans, and hence you should specifically be asking for it, or you can just learn how to measure them also. The other investigations are the MR, which is magnetic resonance imaging, or MRI. They're not usually routinely done, but they are usually sometimes when you have a vascular invasion and you want to do a MRA. Nowadays, we do more of a MR angiography, then you can do this imaging and then you can look for these masses and the vascular invasion. The transthoracic echo should be done when you are specifically finding some mass in the middle mediastinum or the anterior mediastinum, which is protruding backwards. So sometimes there could be an impingement on the cardiac structures leading to right ventricular outflow obstruction. very rarely, sometimes they can invade into the pericardium, and hence we have seen, especially for the malignant growth, they can invade into the pericardium and the myocardium, and hence you should be very, very cautious about it, because when it will be operated upon, they will be stripping the pericardium. A lot of arrhythmias can happen, and these arrhythmias may not require drug treatment as such, because they are because of the direct manipulation, and hence they are not responsive to the medical management as such. And hence we should be cognizant about these type of arrhythmias in these patients. Spirometry, this was one of the tools and still being used, but out of the various tools that we usually look for, there are two things. One is flow, and second is you have to look for the peak expiratory flow rate. The peak expiratory flow rate, it is one of the very good marker to look for the airway obstruction, and less than 50% predicted has been associated with a high risk of complete airway obstruction during the anesthetic management. And hence, you should always be looking for PEFR when you are looking for the spirometric results that you are obtained from. And it has been found that the significant reduction in peak flow rates in some patients, even with normal CT scans. So this means when we say CT scan is a static imaging. On the other hand, PEFR or spirometry is a dynamic changes. So it has been very well seen in these mediastinal masses that various dynamic changes happens to the airway during the patient's breathing efforts, and hence we should also be looking for these dynamic changes, and it becomes important to see for the loops and the PFR in these patients to make some diagnosis and pick them the high risk population. Now, just to summarize what I have just mentioned, that those patients who probably would have high risk of intraoperative cardiorespiratory complications, you need to look for the various predictors, which include increased dyspnea, SVC syndromes, pericardial effusion. They could have significant narrowing of tracheal diameter, mediastinal thoracic ratio of more than 50%, and supine PFR of less than 50%. Any of these patients requires high risk. Children versus adults. Children, as I mentioned earlier, they have a little more chances of complete airway obstruction because they have a compressible cartilaginous structures, and hence you should be very careful when you are managing these patients, these kids for perioperative management. Now, when this patient is posted for this, now rehabilitation is one of the important components for our anesthetic management. We should try to rehabilitate it. And this is just to increase the patient's cardiorespiratory reserves with the main aim to prevention of cardiorespiratory complication in these patients. And hence, we can follow this basic rehabilitative tool, which is usually applicable for all the thoracic surgeries, and they are even applicable for mediastinal surgeries also. Stop smoking, dilate the airways, loosen secretions, remove them, adjunct medications if there are chances of infective pathology, and prepare the patient for various education motivation so that they can cooperate for physiotherapy, deep breathing exercises, psychological preparation. So this will help the patient to have support system in the post-operative period, and hence the outcomes becomes much better. So just to summarize what I have just mentioned, that these patients who are posted for any type of surgeries with mediastinal masses, you could have respiratory compromise with reduction in the FRC. They could have loss of spontaneous diaphragmatic movements, and hence you should be cautious when you are using the drugs. They could have relaxation of tracheobronchial smooth muscles because of, I just mentioned, because they can have impinge or compress over these tracheal structures. They can lead to the tracheal cartilaginous softness. They can have invasion into the vessels and increased tumor blood volume. They can have increased loss of blood also. And they could be compressive symptoms like tracheobronchial, SVC, heart and pulmonary vessels. So this is something which I have just mentioned. So when you're assessing these patients, try to make a cognizance of it so that you can manage them. And based on this, you can stratify, because you have to prognosticate, you have to do ASA physical status grading for these patients. So you can just, based on these findings, you can keep them safe, unsafe, and uncertain, depending upon the predictors which I have just disclosed to you. And based on this, you can prognosticate and help the patients. Obviously, these patients require a multidisciplinary involvement. So usually the physician, the physiotherapist, usually we get a bypass of cardiac anesthesiologist is a main concern. The vascular access is an important concern. Now, many of the time, these patients would require a cardiopulmonary bypass, but remember, cardiopulmonary bypass is not an emergency procedure because securing the venous access for cardiopulmonary bypass takes some time, and hence it should be prepared rather than an emergency procedure. The blood product should be available. You should be a little comfortable for the airway assessment, and hence make a plan for airway management, whether you are preserving the spontaneous breathing or you can obtain them if based on your airway assessment. You should be very ready that the intubation should be beyond the point of obstruction, that is beyond the point of the mediastinal mass that is impinging the airway, and you must have backup plan. I'll be coming a little later. What is to prepare yourself, prepare your OT appropriately. Now you know the features, now you know the concerns of the patients, now you know what all things are required from cardiovascular point of view, from the airway point of view, and hence accordingly you need to keep your difficult airway calm. If required, a cardiopulmonary bypass equipment, or it should be posted in that OT where it is available. Vascular access equipment, because they can bleed it. You cannot put the vascular access in the upper limbs. It has to be in the lower limbs because that may be bleeding. And we can use various other tools for pain management and ultrasonography machine that can help you to look for various complications. Have appropriate drugs based on your planning, and IV-fluids, blood and blood products should be there. With regards to the monitors, apart from the standard monitors, these patients would require beat-to-beat BP monitoring, and hence it requires the placement of arterial catheter in these patients. Probably you will also require ABG, so that's the most important. The CVC catheter, central venous catheter, the measurement of CVPs is not a very good option, but the trends can be seen in these patients. But your fluid management should not be based on the CVP because it will be very artifactual in these patients because of the direct handling. And hence, that's why you can use at times, especially the major surgical procedures, you can use the cardiac output monitors. Vascular access, as I mentioned earlier, if you on your assessment you find that the superior vena cava is involved, you should be looking for the access in the lower limb so that the blood, the fluid, and other products can be given to these patients. With regards to airway management, try to look for 3 plans. Now, these are the main options. They are based on your assessment. In case of any difficult airway, significant compromised airway, which I just mentioned about the predictors, you should plan for awake fiber optic intubation. In case, if you think that the airway compromise is not too much, it's mild to moderate, then you can think of inhalation versus intravenous induction agents. And this would depend upon, again, the obstruction. If it is moderate, try to look for inhalation because you can control it much better. Intravenous, the controllability is not too much, and hence it may not be a good option. Spontaneous versus muscle relaxant, it is absolutely based on the respiratory compromise. If any doubt of respiratory compromise, don't try to give them a neuromuscular blocking agents. Keep the patient on respiratory spontaneous respiration, and preferably, if significant obstruction, awake option would be the best option in these patients. So this is what I've just summarized. The choice of the induction agents could be either propofol or ketamine in case if you're using intravenous. For inhalation, you can use the sevoflurane, which remains the best option. But yes, in case of any doubt, go for the awake fiber optic bronchial intubation because that gives you not only the assessment of the narrowing of the trachea, and you can keep your tube or placement of tube beyond those obstruction, and hence you can assess directly for these patients. The induction of anesthesia, you should remember when you're inducing these patients for anesthetic management, the positioning is important. So you should be asking in the preoperatively, which is the best position in which these patients are comfortable. Many of these patients will be a little head up. They may be in lateral position because depending upon the site of the mass, they will have symptomatology. So do ask the patients which is the best position in which they are comfortable. And during the management of the induction of anesthesia, try to maintain that position particularly till your airway is secured so that these patients are not going into respiratory compromise. Now, sometimes the acute airway obstruction still can happen, and that's why you need to have plans and action. You can change the patient position, change the tube to a DLT, making the tube endobronchial because you are now bypassing the obstruction. At times, you can use jet ventilation catheters because you may not be able to put a tube. A fine catheter, fiber optic guided can be put, and you can use jet ventilation. You should be a little well versed about the rigid bronchoscopy also because through rigid bronchoscopy, these structures can be lifted up and airway potency can be maintained. And at times, it may be required, especially the malignant structures, because they are infiltrating and then they collapse. You may not be able to lift up. An emergency stenotmy to lift the mass of the airway is also required. And hence, the surgical presence should be there for management of these patients. So fiber optic intubation remains the safest technique for airway management. This is just to summarize. Be cognizant about the topical airway anesthesia and nerve blocks for these patients so that the patient comfortable, he cooperates, he does not strain during the airway management because even the straining can lead to airway compromise. Inhalation induction, second best option. It preserves spontaneous breathing and the chances of airway obstruction still can exist. So based on your predictors, take a decision of inhalation. Intravenous induction, no respiratory compromise. You can use propofol or ketamine, but in case of any doubt on imaging, on clinical symptomatology, try to avoid this technique. Now, various hemodynamic change and concerns that can happen in these patients during induction of anesthesia, they can collapse because, as I mentioned, as for the airway, if the mediastinal mass is sitting near the vascular structure, after the induction of anesthesia, the structures tend to collapse and there could be a profound hypotension because of this mass leading to compression on the various vascular structures. And this physiology, as we just discussed in the previous session also, can also be affected by spontaneous versus controlled ventilation, and hence the collapse can happen. So what needs to be done? First, maintain the best position in which the patient is comfortable. So do ask that whether patient feels syncope, dyspneic, or any type of lightheadedness in a particular position, try to avoid those patients. Using induction agents with minimal or favorable effects of hemodynamics with appropriate fluid resuscitation is important aspect of it. And try to maintain spontaneous ventilation using inhalation, or preferably you can go ahead and get away with the patient. For maintenance, even after putting TUB, when they are doing the surgical procedures, there are a lot of handling of the tissues. There could be tractions on the airways and vascular structures, and hence the airway obstruction and cardiovascular compromise can happen during the surgical procedures. And hence it becomes very, very essential to monitor hemodynamics and respiratory mechanics onto your monitor to look for these early changes, and then you can ask the surgeon to wait for a moment or to remove the mask or to remove these ligatures or the compressive retractors to prevent these type of complications. Similarly, hemodynamic compression can happen, especially when they are retracting the masses. They can compress on the structures, sometimes prevent bleeding. They make a loop, ligatures according, and hence you should be very, very cautious. Also, there could be some amount of arrhythmias if they are working near the cardiovascular structures, and that can lead to the various type of cardiovascular changing, including hypertension. In case it happens, stop the surgery, look for the reason, whether it is because of bleeding, whether it's because of manual handling, and based on this, you can take a decision. If manual handling, stop the surgery. Because of bleeding, you can give the fluids. If not responsive, you can start thinking of inotropes, vasopressors, specifically when it is bleeding to a large extent, and then you can go ahead and give other products also. For dysarrhythmias, it's usually benign, but in case if they are leading to hemodynamic instability, look for the reasons. It could be electrolyte imbalance, it could be fluid loss, and you can accordingly give the management for these patients accordingly. For postoperative management, these patients require a very smooth emergence and extubation, because these patients probably, because of the masses, the residual effect will still be there. The airway structures which has been softened up, the cartilage softening can happen. They can manifest in the form of various airway obstruction. There could be various injuries during the surgery, like left recurrent phrenic nerve or pneumothorax, and hence should be taken care of. And hence, extubating these patients over a flexible bronchoscopy is always a good option. So we have to maintain a good depth of anesthesia with good analgesia so that they don't buck and cuff. And then you can use flexible fibroscopy directly, or if you have placed a double lumen tube, you can replace with some supraglottic airway devices, specifically second generation, and replace them over a flexible bronchoscopy so that you can see whether the structures, especially the airway structures, are collapsing. A smooth and controlled extubation is must for these patients. Try to avoid cuffing and bucking. And extubation under deep lens of anesthesia with the goal to minimize airway reactivity, cuffing, and sympathetic response is important, because these patients for some time are very labile with regards to cardiorespiratory and airway structures. The post-operative complications can happen. So when these patients are shifted for post-operative care, try to look for the hemorrhage, the airway compromise, or other things. Sometimes, like for example, a massive amount of blood loss, try to look for these things also. Coming to the last aspect, the post-operative analgesia. There are various options that you can use for analgesia techniques for these patients. Usually it is multifactorial, and you should use multimodal analgesia for these patients. You can use the systemic analgesia like opiates, anacetes. Usually it is a combination. Nowadays, intraoperatively, we also use dexmedetomidine for having opiate sparing effect, because we want the patient to be fully awake at the end of surgery, and hence you should use opiates very carefully in these patients. We also use a lot of nerve blocks. The literature is full of nerve blocks now, just not the intercostal nerve blocks, intraperennial analgesia, but also the upcoming newer blocks like the SAP block and the ESP block are being used for these type of procedures, and hence can be done for this. Especially when the tumors are infiltrating in the trachea, we use a good amount of cryoanesthesia or use of alcohol in the intercostal blocks so that the permanent damage which has happened does not lead to post-Rakesh syndrome, and hence these type of things can also be used. The regional anesthesia is one of the commoner things. Thoracic epidural and paravertebral remains the gold standard. As I just mentioned, the ESP and the SAP blocks are the emerging one. So to summarize the various management plans for the management of mediastinal masses, when you are managing these patients, try to look for the various signs of tracheobronchial compression, assess them preoperatively, monitor them intraoperatively and manage, and also the residual effect in the postoperatively needs to be looked for. So hence, these compressive symptoms can manifest throughout the perioperative care with different findings, with different management plan, and hence should be taken care of. The vascular compressions, whether we talk of superior vena cava or pulmonary vessels, again, they can happen pre, intra, and post-op, usually not much phenomena. Post-op may be related to bleeding, but based on this, you need to take appropriate measures, assess these patients, plan the induction accordingly. In case they are happening intraoperatively, whether it is manual compressions or bleeding, take the things accordingly. Compression of heart and pulmonary catheter, again, preoperative evaluation because of mass, intraoperatively because of mass and surgical manipulation, and hence you should be carefully assessing, picking them early, and managing them accordingly is important. Intraoperative dysrhythmias, usually benign, maintain a good depth of anesthesia. In case if they are persisting, you can wait just for a moment from the surgical aspect, and then you can look for the other parameters which can lead to dysrhythmias. If reversible causes, reverse them. If not, just monitor them. If hemodynamic is stable, they are usually benign. So this is the main summary. If we have some more time, Dr. Edwards, so yes. Maybe we can take the questions or...
Yes, sir. So you have almost covered all areas of the topic. So there is not much questions. There is one question from Professor Parthasarathi. You already discussed in the presentation itself. That is, question is the role of CVP monitoring in such cases. Maybe a dynamic.
CVP monitoring, if you see from majority of surgical procedures, CVP is not a good tool for the fluid replacement or for looking for the management of fluid and blood products. But sometimes we use it as a vascular access, number one. Sometimes we use it looking for the trends. So the best modality will be use a dynamic monitors, like for example, say cardiac output monitors, which are based on the arterial waveform analysis, and these will give you a better option with these patients. CVP will not be a good option because they are working the near vessel in the mediastinal with the great vessels, and hence the artifacts will be too much to take some decision.
Thank you, sir. So excellent presentation covering all the aspects of this mediastinal mass. It will be very helpful to the postgraduates for exam point of view. Thank you. Thank you so much, sir. For
Thank you, sir. Thank you so much.
Thank you. We will move on to the next session. I invite Jennyl. He is a good friend of me, and he is colleagues. He was working with me for the past 5 years, and I know how much hard work he put for preparing every presentation. And he is a well-known trainer in the ultrasound guided blocks throughout the India. So his area of interest is regional anesthesia and anesthesia for elderly, geriatric anesthesia and orthopedic anesthesia. I welcome you for this online anesthesia, Jennyl. Over to you, Jennyl.
Thanks a lot for the kind introduction, sir. Let's begin this topic. This is mainly for PGs who does epidurals. So let's see about, I would like to call this topic a segmental epidural, science behind congruence. What should I speak? I thought of whether I should speak, tell you about the zone anatomy of the epidural space, which you can see the parasagittal. Should I speak about the parasagittal or the parasagittal oblique technique, where we will be able to see the interlaminar space? This is how you learn to mark your interlaminar space from T1 to L5. These are thin patients where we can easily perform an epidural. But in these patients, obese patients, it will be very difficult to find the upper thoracic epidurals mainly. Let's see. And And then I thought, should I think of presenting the drug spread in the epidural space and validate with my imaging studies, which I have done in an MRI. This will be much more interesting. And also, I like to tell you that this is a regional anesthesia. This is a fight against connective tissue barrier. And I will also like to explain why this connective tissue barrier in segmental epidural. And if you place a catheter in the epidural space and you give the drug, why does it take 10 to 15 minutes to start the onset of action? That's why I want to call it as a connective tissue barrier. Let's see about spinal anesthesia. If you perform a spinal anesthesia at the lower lumbar level, you will be able to block 13 segments each in 26 segments, just like that with 3 ml or 4 ml of 0.5% bupivacaine in the subarachnoid space. But this doesn't happen, but the onset is around 3 to 5 minutes, but this doesn't happen in an epidural space. Look at the concentration. When you look at the concentration in the subarachnoid space, you place 3 ml, which is mixed with 40 ml of the CSF in the lumbar space, and it gets 10 times diluted. The concentration itself 10 times diluted. And we are placing in the epidural space is 0.5% concentration. Still, we are not able to get the onset as quick as possible in a spinal anesthesia. What happens in spinal anesthesia? The CSF and the LA get a 30-degree mix-up around your spinal cord. How does it happen? It passes through the pia mater, and you have natural fenestrations in the pia mater, and finally to reach these are your naked axons. That's how the blockade happens in 3 minutes, I would say. But still, we are not able to achieve this with the 30 ml of local anesthetic in a brachial plexus block. Why? Because you can see a dense connective tissue here. So, dense connective tissue in an epidural space is, this is your ligamentum flavum. What you see here is the ligamentum flavum, and this is the dura mater. So if you place the drug into the subarachnoid space, the onset is 3 to 5 minutes. But here, if you place the drug just above this dura mater, the drug has to diffuse off into the dura mater to get your onset. You can see here the anterior dura. This is a spinal cord. This is the intrathecal space, and this is a posterior dura. And outside, you will see an yellowish thing is a ligamentum flavum. And you can see here, this is a dura which is opened up. And after that, you can see the thickness of the dura mater and the spinal cord. This is the intrathecal space. If you see in electron microscope, what is the thickness of the dura mater is 250 to 400 microns in diameter. And it varies from individual to individual. So the local anesthetic has to pass through this dura mater to get into the subarachnoid space and to bath your spinal cord. So I did an MRI study. I placed a catheter, I performed an epidural at T7, T8, placed the catheter 5 centimeters inside, and first I injected 2 ml. Look at the spread. Look at the spread in the long axis. It comes from just 2 ml of injection of the galadinum isotope, and it covers from T5 to T9. The 2 ml doesn't mean that 2 ml sticks to one segment. I will show you in the cross section what happens here. The drug just settles in the posterior epidural space. But if you inject 15 ml, here it comes from T3 to approximately T11 and T12. That's how the segmental epidural works. Let's see about cross-section. If you inject 2 ml, and then you can see here, this is the posterior epidural space, this is the anterior epidural space. What happens here is, as I can see here, to get a good dense blockade, the drug has to spread around the anterior epidural space and also the posterior epidural space, and the drug seeps out this foramen to produce a dense blockade. These are the next with 2 ml of local anesthetic. After injecting 15 ml of local anesthetic, let's see what happens. After you wait for 15 minutes and you have injected 10 to 15 ml of local anesthetic, you have performed an epidural at T7 and at T8 and injected 15 ml and waited for 15 minutes. You can see here the drug spreads into the anterior epidural space. See here, the drug surrounds the dura mater and also exits into the foramen. You can see here, and well anterior. This is how the time takes. The 15 minutes is for the time for the drug to spread from the posterior epidural space to the anterior epidural space and exit out to the foramen. That's how the epidural works, and that's why we have to wait for 15 minutes. And the drug has to diffuse off into the dura mater, and then you have to it has to take up by naked axons. I have performed a few cases of segmental epidural, cervical epidural, caudal epidural. I would like to share some few cases where I have to expose the patient's face also. So this is a fungating mass EM breast with the brain metastasis, planus cervical epidural, and a femoral block for wide excision. Yeah, it's a cervical epidural, the catheter threaded downwards, and you give around 10 to whatever the desired local anesthetic. Either you mix with lignocaine with adrenaline and 0.5% bupropion that I do. First, I always start with 2% lignocaine with adrenaline, 10 ml, and then equal mixture of 2.5 ml and 2.5 ml lignocaine with adrenaline and 0.5% bupropion. And I first give 10 ml and then see the response, and then you as you have the catheter, you can grade it and give further. So in these cases, you give 10 ml of 2% lignocaine, and then you assess, and then you give the further drug. You can see there the wide excision is done, and the SSG is taken for skin grafting. So there is something called as ultrasound assisted epidural anesthesia. These are the challenging cases, obese patients you get, where it's very difficult to perform, and the scoliosis patient you perform an epidural anesthesia. So how do you do this is you have to mark your interlaminar space. How do you mark your interlaminar spaces? See, this is how you slide your probe in a either patient is sitting or lateral. You slide your probe from below upwards, and you so this is your sacrum. This is the L5 vertebral spinous process. This is the L4 spinous process. This is the L3. You use the M mode in the midline, so you get the interlaminar space in the midline. So you mark your interlaminar space like that, and this will be the C7. So this T3 and T4. So how I do is mark your interlaminar space, go 0.5 centimeter lateral to the spinous process, and you guide your needle cephalomedial. So this is a hanging drop technique. You can see the local anesthetic is getting sucked in. So the next patient, these are the erect spines. So it's very difficult to flex them. Even though if you flex them, it's very difficult to position these patients with the strict stuff erector spinae muscles. So what I will do is I mark the interlaminar space with ultrasound, and I mark the L1. If the patient is coming for inguinal hernia, you can start your epidural here. So this is how the 0.5 centimeter away from the midline. As you go in, then you have your local anesthetic hanging drop, and as you go in, you will get your So you will feel the gritty sensation of the ligamentum flavum. That's what we have to feel here. So as you feel the gritty sensation slowly, and then the hanging drop that gets sucked in because of the negative pressure in the epidural space, and then you can thread your catheter and give the blockade. So I like to run few cases where we have performed a segmental epidural for few cases. So this is a case of mesh repair. You can see here the epigastric hernia is from T6 area to T10 area. So you perform the epidural at lower thoracic T8, T9, same hanging drop technique, and then you thread the catheter. Don't thread the catheter above 5 centimeters from the desired place you got. Patient was sedated a bit. So here they have. So here I have given, if you do the lower thoracic epidural, always start with 10 ml 0.2%, 2% lignin with adrenaline, and then you further grade it. It won't be needed if you perform a perfect epidural in the perfect space, and then 10 ml of 2% lignin is very sufficient to produce a dense blockade. And if the surgeon finishes in 45 minutes, it's more than enough. Or else you need to then give a few more 5 ml of equal concentrations of 2% and 0.5% bupropion. This is an epidural block for hernioplasty. So you can see here they are pulling the cards. They opened up, and when I asked the patient to lift up, see the drug should not tend to descend below the L2, L3, and L4. So you place your epidural catheter at T10 and T11 level, and then give 8 to 10 ml of 2% lignocaine with adrenaline, and then you proceed on if you have not achieved a successful blockade. This is a rheumatoid heart disease patient with MS for hemorrhoidectomy. So I have performed a caudal epidural for this patient. When I asked to move the patient limbs, patient is able to move, and patient is not being sedated. Patient can vocalize. Well, this is another patient who's come for hepatojejunostomy. This is a long procedure. This is a long procedure. So yeah, I have performed at T7, T8. This is a midline laparotomy from xiphisternum to lower pubis. So you can see here the liver is moving. You can see from 11 o'clock to 9 o'clock to 11 o'clock the hemodynamics. They have removed the gallbladder. You can see here it's around 10 to 12. From 9 o'clock we started. It's been around 3 hours. So they have finished the anastomosis. Now it's around 2 o'clock. From 9 o'clock to 2 o'clock. Patient is being. Even after 4 hours of surgery, you can see here the patient is moving the limbs. The abdomen is all relaxed, and they are able to close it well. At the end of the procedure, patient is able to move. This is around 2 o'clock. So patient is able to sit up in the right in the operating table. Now, before shifting to operative ward, patient is able to sit up comfortably, and they will be able to walk also. So this is how, and these are the patients you get in emergency cases, duodenal perforation. They're very sick. How do we get them in epidural, segmental epidural? So you have to perform an epidural at T7, T8, and then give same thing, whatever I said, 10 ml of 2% lignocaine, and then you graded with 5 ml of equal thing. And they're able. So here, their patient is again able to sit up, and when asked for pain or any discomfort, and patient itself is moving to the post-op ward by himself. This is how the magic of segmental epidural. And this is a case of left side pulmonary fibrosis with multiple bullae coming for total abdominal hysterectomy with BSO. This is a nice case. Same thing, any fan and steel incision also, you can place your catheter in the lower segment, lower epidural space, thoracic epidural space. You can see the big mass there. And patient is able to and patient is able to lift the legs, flex the legs, cross the legs. All kung fu maneuvers can be performed on operating table. And the surgeons were very cooperative. You can see the huge ovarian mass. And these are cachexic patients who have come for feeding jejunectomy. Surgeons usually go for a midline laparotomy, laparotomy incisions. So this patient was sedated a bit. And you can see here they are placing the after feeding seizures, and they are closing it. And when asked for movements, they are moving the limbs. So this is another difficult patient, the scoliosis coming for gastrojejunectomy. Severe kyphoscoliosis, very difficult to position these patients for epidural also. And when that time, this is a restrictive lung disease. That time we didn't have an ultrasound to look at the interlaminar space. So what I do is, this is a different technique. You can see a spinal needle there and an epidural needle there. So rather than pricking the patient with a 18 gauge epidural space too much, which is very cumbersome to the patient, so what I do is I use a small spinal needle, walk over the lamina to get into the interlaminar space, and in the same direction above it, I place the epidural needle and go through it. This is how we can see the spinal needle there. Spinal needle is always a guide. Not you don't get into the subarachnoid space. So this is another 0.5 centimeter below the spinous process. Then you can patient after giving local anesthetic, you are able to get the position in supine position, padded in the gluteus, so that the kyphosis, the shoulder, then they are able to. This is also a midline incision. They have done a gastrojejunectomy. This is another patient for severe kyphosis patient. for hemicolectomy. So you can see the severe kyphoscoliosis and the restrictive lung disease. There, where we had that time we had an ultrasound, so we are able to locate the interlaminar space and successfully do an epidural at that place. And then the same here, always when these severe kyphosis there, you have to pad the gluteal region so that then they're performing the hemicolectomy. And patients rock stable hemodynamics. There's something called as ultrasound, rather than ultrasound guided, this is assisted. There is something called as ultrasound guided epidural anesthesia. How do you do that? So if you are not able to, with the patients coming for abdominal procedure, you are not able to, obese patients, you are not able to get your thoracic epidurals. There is always an advantage using a stimulated epidural catheter from your lumbar to the thoracic. See, I'm using a small ultrasound abdominal probe to locate my needle till the ligamentum flavum, and then you plunge it, and then you the LR syringe and get into the epidural space. I will show you how the ultrasound, when you get the needle, I will show you that also. That's a space. So this is a spinous process. This is the posterior dural complex. This is the anterior dural complex. The needle has to come from this area till here, where you have the ligamentum flavum. So slowly guide your needle. You can see a needle is coming in that, and exactly in the place you needed. Now we are here. So you stop there. Then you can use your LOR, and then you hydrodissect the epidural space and see with your ultrasound to see the denting of the posterior dural complex. You keep your ultrasound like this, and you give some local anesthetic. You will be able to see the denting of the posterior dural complex when you give this local anesthetic. So I didn't give much because I need to stimulate. I'm going from lower lumbar to thoracic. These are stimulating epidural catheters with stillets. So first, as you stimulate, so make sure the patient, because tell the patient, educate the patient well. Now you have a stimulation of your lumbar nerve roots. As you go up, you will be able to see the stimulation of your abdominal muscles. So at that desired place, you stop your threading of a catheter and fix the catheter and go on proceeding with the surgeries. So there is another technique which is called as epidural block unilaterally. How do you block either your upper limb or lower limb unilaterally? We tend to go with a 90-degree fashion into the epidural space. If you want it either which side you need it, you just rotate the epidural needle in the 45-degree and thread your epidural catheter after getting into the interlaminars, after getting into the epidural space. So I have done intertrochanteric fracture under epidural block, but one limb will be only blocked. So the surgery is on the left side. Patient is moving the right limb, and you can see they are fixing the femur fractures. Patient is unable to move there, and you can see the patient is able to sit immediately after surgery. A very cooperative patient, and he is given a pleasure to walk after the surgery. And you can see so the patient is happy and he is immediately walking. So these are the challenges you will get, and you can always do an epidural magics in all different manners. So the future of ultrasound is getting more and more. Now we are having to 18 megahertz probe. So I had a research center where they were using around 250 megahertz, 400 megahertz probe, 700 megahertz probe, where the plastic surgeons will be using in future. They are seeing this is a mouse and this is being anesthetized. They are looking into the femoral nerve and they are seeing that. So the future is always a lot to come, and you have to play a lot with ultrasound. And thanks a lot for the opportunity. Thank you.
Thank you, Jennyl. So for a wonderful presentation. I asked for your segmental epidural, but you have talked more than that. It is unilateral epidural. It is a new thing to all of us. So there are questions in the chat box. Guru Sandhya, are you there? Because the question is from Guru Sandhya, I think she will ask directly to you. So he asked, previously I was mixing the local anesthetic agents. Now I changed my practice to, after I have heard from you. After heard from you, the stalwarts, she has changed his practice. So what is this question? I don't know. So the question is, what is the advantage of mixing the two local anesthetics you feel, sir?
See, for lignocaine produces better relaxation than bupropion. First, you start with 10 ml of 2% lignocaine with adrenaline. So as the surgery proceeds, you need longer action of the bupropion. So the mixing of 2% lignocaine with adrenaline and 0.5% mixing of 2% lignocaine with adrenaline and 0.5% bupropion does not reduce your local anesthetic concentration, because there are two different isomers that is what they say, and I'm very sure the concentration doesn't come down even if we mix it, or even if we give the plain 0.5% bupropion alone. Both are the same. But when you give 0.5% bupropion, the onset may be a bit late. But when you mix it with lignocaine with the adrenaline, the onset is a bit faster.
So another suggestion from Professor Parthasarathy is, in total abdominal hysterectomy with bilateral salpingoophorectomy, that involves the sacral segments. So if you give a segmental epidural, the clamping of the ligament will cause pain.
Sir, the sacral segments I don't think much they are involved. As you see here, I have performed few cases to total abdominal hysterectomy. The patients, they walk from the operating table. They see it's a fan and steel incision. So they till L1, and the abdomen, the peritoneum is also involved. So you need to block till T6. So you place a catheter just above the T7, T8. You block from T6 to L1. I don't find much. I have done few cases, but I don't find any much difficulty in performing in segmental epidural for TAH.
So another question from Dilnas. How many ml in unilateral epidural for fracture of femur?
Ma'am, it's around 8 ml of 2% lignocaine is with adrenaline is much enough. When the surgeons finish off, usually the surgeon finish off fast in 45 minutes. But if it prolongs, you can always suffix with another 3 to 4 ml of 0.5% bupropion.
So how often you will go for top up?
It's 45 minutes for the 45 minutes to 1 hour for lignocaine with adrenaline, and then again when I use 0.5% bupropion, another 1 hour. So I top up for if it's a prolonged surgery I have showed for 4 hours. I always top up in gradients, and not like 10 ml as such into the epidural space. I always go with 5 ml of 0.5% bupropion for 1 hour, and then another maybe 5 to 6 ml I may increase like that. So it's like that.
So how do you calculate the total volume? Will you go The
So
ML
I
per
go
segment
up to maximum. I go up to if it start. You need 10 to 12 ml of lignocaine in the adrenaline. So another 10 ml of 0.5% bupropion. So it will cover up at around so first 1 hour and then 1.5 hours. So it's around 2.5 hours. So in that time, the metabolism of your local anesthetic in that 2 hours, the lignocaine, the adrenaline goes up. And then what's the then maximum gets the plasma concentration of 0.5% bupropion what you use, and then you grade it for 1 hour 5 ml 5 ml. You can then reach up to 15 ml of lignocaine with adrenaline, and then another 15 ml of 0.5% bupropion.
Will you take the segmental, that is ML per segment calculation in your volume calculation?
That's what I found was in my MRI imaging. What they say, it is 1.5 ml for thoracic segments, and 2 ml for lumbar segments. What they say is, say if you give 1.5 ml in thoracic epidural, you will have this much amount of blockade from this area to this area. So it is not fixed. I have given 2 ml. You can see the spread from T5 to T9. The drug spreads from in the posterior epidural space. So it is not fixed. It is to me it is not fixed. It is 1.5 ml or 2 ml for the lumbar vertebra.
So it's an imaginary calculation.
Yeah, it's an imaginary.
So that is the answer for Professor Parthasarathi also. But in our teaching, we are saying that ML per segment.
Sir, that's what that's what I found in my MRI. I did around 3 to 4 MRIs to see the 2 ml whether how much it spreads. It doesn't spread into the one segment. It doesn't get fixed into one segment. It always seeps down through the posterior epidural space.
So for postgraduates, it is for practical purposes. For exam point of view, go for per segment.
Yes, sir. Yes, sir.
So any other questions? So there is no question in the chat box. So with that, we will come to the end of this session. Thank you very much, Jennyl, for your wonderful session.
Thanks for the opportunity. I think I have taken more time. Sorry.
No, sir. It's an interesting topic. Many people are more involved in your video presentation. So it is there is no question of extending your time. So we are happy to have you in our session. Thank you. So with that, we come to the end of this session. Next week, we are having a case discussion on the respiratory system. So don't miss it. Thank you. Thank you, one and all. Thank you, my team. Thank you, A1 Logics. Thank you.